this has really changed the standard of care of my practice, and why, for example, if it ever does happen that my Artemis or my Insight later on was not functioning well, it would really cripple my clinic, even though no one else was using it around the world. So that's kind of like a gives you a data point. And my financial interest is because I obviously was the first to think about this idea of scanning the epithelium and the cornea at a time when everyone said it was a silly idea of no use. And sticking to it for many, many years, it ends up being obviously of a lot of use. And I was very lucky in that respect because I did invest a lot of my time into it. So this is, the prototype imaging that we got originally from the engineer prototypes. And as you know, this is an incredibly sophisticated scanning motion mechanism. It can move the transducer in any direction. So if you wanted, you could program it to follow the contour of the sclera, then the cornea, then, you could do anything you want. So it's a bit over sophisticated for most applications, but there it is. And it's been FDA approved for many years now, and it's CE marked approved in Europe. So what I'm going to do is I'm going to go through the 4 major areas of how we use VHF digital ultrasound, obviously in the epithelium and intrastromally within the cornea, but for anterior segment, anterior chamber modalities, but then the posterior chamber modalities. And I'm going to talk about this in the context of OCT because, clearly that's another technology that has a lot of overlapping applications. But, as I said, I started measuring the epithelium in 1991. I was told it was of no use by everyone. I was presenting all over the place as a resident and as a fellow. And, I always used to get my slot on stage, but not much interest. But I managed to pepper the literature. I have over 40 publications on just epithelium. So not all the other applications, but just on the epithelium. So, a lot of my friends always say that my career has been very superficial. But, we learned a lot. And one of the things that's become the most, the driving force behind commercialization of this technology, and the driving force behind the commercialization of anterior segment OCT, was when I started to describe how we could use it for screening for keratoconus. And in fact, I was showing data that effectively using epithelium, you could increase your surgical volume by 7% and avoid operating on these very rare corneas that look normal but aren't because they're subclinical keratoconics. So the whole of epithelial application in screening for keratoconus is something that's becoming mainstream now. It's taken a long time, but it's becoming mainstream. Most of you know that, keratoconus was diagnosed only from the front surface, and then the mid-90s we got back surface from orb scan. So I introduced the epithelium, in the early 2000s. This generated the interest in the industry. So now we have epithelial maps from OCT machines. But essentially, this has been, really a long time in coming. And what was interestingly difficult to publish, because this paper was rejected from ophthalmology by some very backwards thinking as editors, but it's my most cited paper now. It was sent to the Journal of Refractive Surgery, and that is, the normal epithelial thickness profile. How often do you get an anatomy paper in eyes, in the 21st century? So what we found was quite striking. We found that the epithelial thickness profile was not a single layer of thickness. We found that, it was 50 microns in the middle, like many people knew from histology. But what we found was that there was a superior to inferior difference and a nasal to temporal difference in thickness. And this profile had mirror asymmetry. And so this is interesting because it led to essentially proving how it was that we understood the epithelium forms and why it becomes a certain shape and why it changes in LASIK and all that. We've described how, as the cone progresses in keratoconus, so the epithelium becomes thinner over the cone, but the donut around the cone, the donut of thicker epithelium becomes thicker. We described, the differences between keratoconus and normal many, many years ago, and then chose to exploit this difference. And, if we just look at the model here from a very old slide, we think of the front surface, the stromal surface, and the back surface of the cornea, and the epithelium is obviously between those two surfaces. In keratoconus, the cornea bends forward and becomes thinner here. The epithelium becomes thinner over the cone, but thicker around it. That's the donut. And so that's kind of the obvious case of keratoconus versus normal. But then you have the situation where the back surface is only slightly changed, yoked to the front surface, but the epithelium has managed to completely absorb the front surface extrusion of the stromal surface. And so the epithelium hides the cone that is on the front surface. And this explains why in the 90s we were saying, yes, back surface is very important for screening for keratoconus. There was still 100%, well, half the people in the room in 2010 at this meeting at the ASCRS thinking that it wasn't necessary to look at the back surface. I remember that debate. But what really got the juices flowing on epithelial mapping commercially was when I described that you could exclude keratoconus in a cornea that had inferior steepening if you could show that the epithelium was thick where the steepening on topography could be seen. Because obviously, you can't have a thick epithelium over a cone. You'd have thinning of the epithelium. And so this excluding of keratoconus became a volume booster. And I published a paper, 1,500 eyes screened by back surface, 10% of which went into ultrasound to distinguish the epithelial thickness profile. 84% of these were recovered for surgery. And, if you do the maths, that's 7% more surgery and only 1.4% of the eyes rejected for keratoconus, even though 9.2% of the eyes were suspicious from just looking at the back surface. So you've got your back surface over-enthusiastic Bell and Ambrosio algorithm, and then you take the patient to the inside, get an epithelial map, and exclude keratoconus despite the Bell and Ambrosio being yellow or red. And that's a moneymaker. So that suddenly excited everyone. Ron Silverman, who developed all this with me, he did all the mechanics and all the computer science around this. We got an NIH grant of a few $1,000,000. We did an AI algorithm for epithelial analysis, and we found extraordinarily that we could detect keratoconus with 95% sensitivity and almost 100% specificity. So if ultrasound says it's keratoconus, it's very likely to say it's keratoconus. Whereas, as you know, the specificity and sensitivity of tomography, no matter what algorithm you look at, is way lower than this. So using epithelium, we can see corneas that are completely normal in hyperopes with best spectacle corrected vision in low and flat corneas who classify as entirely normal on a Bell and Ambrosio, but in whom the epithelium has the donut shape. And so this is absolutely a keratoconic eye. And that little tiny little, I don't know, just the little, I don't know what on the back surface here, in fact, was the herald of a keratoconic cornea, and that would not have been detected on the front surface alone, and it would not have been detected by the BAD, the big D. So, but the algorithm that we developed with Ron, yes, absolutely, big time keratoconic detection. So here's a scary example where you'd go and do surgery on an eye, and then it'll get ectasia, and you wouldn't know why. The ectasia without a cause case, So for us, epithelial thickness, screening for keratoconus is a big deal. And whereas I will show in a minute we use OCT a lot, we still have about 10, 12% of patients that have to move on from OCT to ultrasound because ultrasound is more accurate and more specific. So other applications of epithelial thickness measurement is in the ability to do much higher levels of hyperopic LASIK than you otherwise would have been able to do if you were only looking at Ks, because you can have steep corneas with thick epithelium and flat corneas with thin epithelium. And this is where hyperopic LASIK got a bad reputation, because we were just using Ks to determine if we could steepen anymore. And it turns out it's the epithelial thickness profile that matters, not the case, and they can actually be contrary to each other. So we published +4 to +7 with only 0.4% loss of two lines, and that's because we're guided by epithelial thickness profile. So, a whole area of ophthalmology that is neglected, which is hyperopic LASIK, is totally opened up by using epithelial monitoring. We've published 2-3 papers on this already. The other thing, of course, is diagnosis in complex cases. And, I have a reputation for being very good at complication repair. It's only because I had the best teacher. The best teacher was very high frequency digital ultrasound. And I was really the student of this imaging technique and biometry technique, enabled me to make the epithelium of each of these complex cases and being able to see what is going on the stromal surface. And we've published numerous papers on how we've used the diagnostic power of epithelial mapping in the ability to treat complications on the cornea. So if we think about the intrastromal applications, here we have the advantage with ultrasound that the signal to noise ratio of the flap interfaces is much higher with ultrasound than it is with OCT. And so whenever you look at a cornea, even 10 years after LASIK, you can still see the interface light up like a Christmas tree all over. Whereas, of course, we know that with OCT, after a few months, this tends to fade. And this means that even 10 years later, we can map the thickness profile of a Hansatone flap, for example, and we know exactly what the RST is in 3 dimensions as well. So this intrastromal mapping is important in enhancement surgery. Topography-guided surgery has finally reached the US, and there's a lot of excitement about that. Well, congratulations for doing that. But, the ablation profiles are asymmetric, and being able to measure what the residual stromal thickness is where the deepest ablation occurs is important, because you just look at the maximum ablation depth and then look at the RST in the middle, you may not be able to do the case. But if you do topographic mapping of the RST, well, then you have a method of knowing exactly where you are. This cannot really be done very well with OCT because you can only see the interface in very patchy areas. Here's an example of a Hansatone flap that was obviously not calibrated properly on the pressure head. And so the surgeon was creating 250 micron flaps. And had this patient had this flap lifted to do a night vision repair with the newly found topography guided systems, you'd end up inducing ectasia in this patient. So we also use obviously this layered pachymetry. For example, in SMILE, we're able to find the interface, find the epithelial thickness profile, and plan the LASIK flap below the epithelium but above the SMILE interface, taking into account the standard deviation of these 3 devices and the 3 surfaces, so that we know, where we are, and we're able to do a very quick healing, easy to do LASIK procedure on top of a SMILE, rather than having to condemn the patient to PRK, essentially the most invasive procedure for the patient after they've come to you for the least invasive SMILE procedure. We have some esoteric publications where we had free caps that had been rotated numerous times and couldn't find the right rotation. We did a thickness analysis of the flap. We're able to rotate the flap back in place, best spectacle corrected vision restored, just knife and fork, easy to do, anatomically based surgery, right? Being able to examine the individual layers of the cornea, where the epithelial ingrowth is, where stromal components of the original flap are, where there's melt, being able to analyze the anatomy of flaps and is also very powerful when you're trying to help patients. Being able to quantify the actual thickness of this, for example, apical syndrome in this small optical zone hyperopic treatment done, on a Vizix in a small optical zone, patient got apical syndrome, being able to fix this by direct measurement of the thickness and PTK, very powerful again. So, intrastromal applications are really important when you're thinking about therapeutics. Now, if we go to the anterior chamber, well, this is where glaucoma specialists are getting very excited about all the different dimensions that can be derived from anatomical and measurements from the angle, angle depth, scleral spur measurements, for ICL sizing, anterior chamber measurements. Obviously, a lot of overlap with OCT, but with ultrasound, you're more likely to be able to see Schlemm's canal. You're more likely to be able to follow the pathway of these, mini implants that glaucoma specialists are using, because OCT obviously is blocked by sclera mostly. There's a whole area of research that hasn't been explored from Jack Holman's lab, where I was working in the early 90s, of tissue characterization of ultrasound. You can do spectral analysis of ultrasound and get a lot of it's almost histological information about tissues. It's like an acoustic biopsy, I think is what Jack Coleman really called it. But that's a whole area that could be used in glaucoma for uveoscleral outflow analysis and things that are very difficult to measure otherwise in the clinic. But I want to get to the big one here. And the big one is the posterior chamber. And obviously, the posterior chamber is the ICL. And OCT has been brought in as the new kid on the block for OCT, for ICL surgery, and that's great. You can measure the white to white and size your ICL, or you can try and measure the sulcus to, the anterior chamber width, but you're either measuring the corneal diameter from the outside or the corneal diameter from the inside. And then you're making an assumption of what the posterior chamber dimensions are, right? So, whether that's larger or smaller than expected is the outliers. And, we have outliers in ICL surgery, and there aren't many of them. It's a few percent, but exchange surgery is traumatic for the cornea, for the endothelium, for the patient psychology, and for the surgeon. And, it should be avoidable because this is quite a simple problem, actually. Understanding where the zonular plane is important for cataract surgery if we're going to finally attack ELP, which hasn't been done yet, a whole other area of science that hasn't been addressed. But you see, where this zonular plane is cannot be seen by any form of OCT, even with a dilated pupil. And you've got studies trying to extrapolate lens visible via the dilated pupil, but that hasn't led to any improvements in IOL calculations. So as you can see, high frequency ultrasound gives us exquisite detail of the posterior chamber, including zonular position. And this, as you can imagine, can be exploited for making the ICL a bulletproof technology from a very good technology. And understanding the exact sulcus and the exact zonular plane, and being able to measure the exact lens rise from the zonular plane, and being able to therefore predict ICL separation, that's the key. And those of us, which I'm going to talk to you about now, using our new formulas, are very excited about the ICL in a way that we weren't never that excited as we are now. Postoperative, of course, we love our OCTs because you could just do a quick scan in air and get a very quick measurement of the volt, but you can't actually see, behind the iris. And that means that in a high myopic ICL, where the thickest part of the ICL is now hiding behind the iris, no information. So while you can get the central volt, you can't get the information from when the ICL is thickest, and you can't therefore map the volt separation. And let's be honest, that is one of the things that if I had an ICL in my eye, that's what I would want to know, is how far is this thing from my crystalline lens. Not only that, but we're able to see where the foot plates are. And this pertains to ICL volt, as I will show you in a minute. All of these dimensions unattainable by OCT. What happens if you have a tilted ICL? We see these frequently, actually. Well, in my early ICL days, I really didn't know what I was doing, but thanks to being able to monitor by ultrasound postoperatively, I started to learn about where I was putting these ICLs. And I started to learn that the placement of the haptics and of the foot plates could actually be a little bit into the sulcus in the armpit, or I could actually, if I manipulate behind the iris, push it down to rest more on the zonules. And these tilted ICLs often are malpositions that don't require an exchange. They just require a little bit of repositioning, a lot less traumatic. Here's a hyperopic ICL with a little bit of tilt, and you can see that, yeah, I had one of the foot plates in the armpit, in the sulcus. The other one was sitting on the zonules. So again, these are the things that you would never know. You know, if you don't measure it, you don't know it. If you don't see it, you'll never know. So all of this operating behind the dark side of the moon becomes, you know, demystified. So when we look at the applications of OCT, and we know that I received one of the very first prototypes from OptoView that David Huang was involved in developing, and they developed an algorithm for doing epithelial mapping, and they showed that they could distinguish keratoconus from normals. Well, that's fine, because you already knew they were keratoconics. And there are a number of publications now from OCT saying you can distinguish keratoconics from normals, but that's obviously pointless, because if you already know it's a keratoconus eye, what's the point of getting the epithelial map to prove that? What's important is the corneas where you don't know if they're keratoconic and whether the epithelium gives you the answer, and that requires the micro precision. So when we think about how in our clinic, how OCTs are used, well, about 80% of our epithelial applications, we do it by OCT. For intrastromal, it's less because we can't always see interfaces with OCT. Anterior chamber, it's the same, OCT and ultrasound, and obviously OCT is more convenient. So for anterior chamber dimensional stuff, yeah, we just use the OCT. But for the posterior chamber, zero, right? There is no application on OCT. And so here's where our insight gets it constant workout all the time. Now, I'm not allergic to OCT. We have, in our own clinic, we have 2 Avantis, we have 5 MS39s from CSO, and 3 Cirrus OCTs with the anterior segment lens. So we love OCT, but we still have to use ultrasound. And why? Because it raises our standard of care. And it raises our standard of care in epithelial screening, as I mentioned, because OCT is not actually measuring the epithelium. It's measuring the epithelium and the tear film as one. And here's one publication showing how the tear film changes in thickness even just during and between blinks. But we can see here an example of a pre-op visit from a patient with a ropey tear film, and there is the OCT epithelial map. And here is after a month of tear film meibomian gland dysfunction therapy, and you can see that the tear film is in better shape and the epithelial thickness profile has changed a lot. Well, has it? No. The tear film has changed, and it has made the epithelium look different on the same cornea. The epithelium is the same, right? So we've done a lot of work and published work on comparing a high-resolution OCT with our ARC-scan Insight, and we found that there was very little difference in the central thickness measurements. They've obviously calibrated them very well using our device, but the differences become greater as you go out towards the periphery. And as you know, OCT only gets out to the 6 millimeter zone. Ultrasound gets out to 9 or 10 millimeters, but we're restricting the analysis to the 6 millimeter zone. You can see that already by the 6 millimeter, the 3 millimeter radius, there's already a 3 micron difference in thickness of the epithelium, and that is where the cones are, right? In these virgin eyes, in that 3 millimeter zone. So That's why sometimes we're missing keratoconus that is visible with ultrasound. Post-LASIK, they've definitely not done their calculations because the refractive index of the epithelium is obviously different. So that doesn't affect us in ultrasound, but it does affect OCT. And you can see that there's a lot of difference now between the actual values derived by the gold standard of measurement, which is ultrasound, and the OCT, which depends on a knowledge of refractive indices, which is obviously not known for epithelium post-LASIK. The other thing we noticed about our OCT devices is that if you just move the cursor one box, like just one little box on the screen, you could be moving, up to 9 or 8, 9 microns just by one little box. So the resolution is lower, and this is because the signal to noise ratio of internal corneal measurements is much lower in a transparent cornea than it is with ultrasound, where you have interfaces that are really echoing physical discontinuities. So ultrasound is much better at interfaces within the cornea than light because the cornea is transparent. So that's a good thing. And our surface localization of 0.87 microns per surface is what leads to this extraordinary accuracy that we can get in mapping flaps, for example, in 3 dimensions. Here you can see at 1 year, this is a smile case that was aborted, and we made a flap over that smile. We left the lenticule in. So that lenticule interface is still visible by ultrasound. Here's the flap, the very thin flap that I made to do LASIK on top. And you can see that by OCT, we're barely able to see anything of this sort, right? There's just no detail. And this is only 1 year later. So ultrasound has its place when you need to see internal interfaces once the edema has gone out. As I showed you earlier, 10 years later, you've got interfaces just lighting up like Christmas trees very, very easily because of physical discontinuities from ultrasound, different from trying to get an optical discontinuity in what is a transparent, membrane, the cornea. So, for example, in borderline cases where we're told that the cornea is normal by Pathfinder, we're told that it's basically normal by the back surface, the big D and all the little D's from the Bell and Ambrosio, and we're not sure whether this is significant. Well, we can know straight away. We can look at our epithelial map from OCT and we can say, well, I'm not sure, it looks kind of even. But then we look at our epithelial map on the inside. And now it's unequivocal. And the insight has the Reinstein-Silverman keratoconus algorithm in there from our NIH grant. And so, it says, yes, this is keratoconus, and we're able to, see this in advance. This patient may have gone through to surgery because the epithelial thickness profile looks even, right, on OCT. So in our clinic, every single patient that walks through the door gets topography and tomography, and every single patient gets an epithelial map from OCT. But still, a good 10 to 12% of our patients still get ultrasound diagnosis because sometimes it goes further and it helps us exclude cases that are actually keratoconic, but it actually helps us rule in cases that an OCT can't tell us is not keratoconic because the epithelial map isn't precise enough. So on to the big subject here, which is the posterior chamber, right? And that's the ICL. And, I don't have to mention this, but obviously we don't want oversized ICLs because that's a bad long-term problem with pigment dispersion, angle closures. And we don't want undersized lenses because of the risk of cataract. And yes, the Aquaport, which you don't quite yet have in the US, but you're about to get, it made a massive difference to the anterior subcapsular capsular cataract rates, massive difference. But as Roberto Saldivar, who has the most experience with ICLs in the world, will tell us, even with the hole, you can sometimes see circular anterior capsular cataract because the ICL is too close and there is, just not enough circulation in the mid-peripheral area where the ICL is thickest and it's still abutting against the crystalline lens. So we still need sizing. And in the early days when Gonvers was raising the alarm about how, 90 microns is the minimum acceptable, otherwise you're going to get cataract. Yeah, all that is kind of a bit old-fashioned, but now we really need a different set of rules for sizing, because it's no longer about avoiding an exchange. Now it's about putting the lens in that's the ideal size, so that in the long term it does the best it can for that patient. Now, correlations with the sulcus were things that were heralded by Carlo Lovizzolo, my teacher in ICL, my original teacher, but others. And Doherty in the States used his FDA data to publish a nomogram that showed that was way better than white to white, using his sulcus to sulcus method. And with Lovizzolo, we did a number of studies of this sort, but we had already done a lot of anterior segment analysis. And I just want to share with you a couple of interesting statistics. So what we looked at was, with high frequency ultrasound, we looked at the correlation of being able to predict the sulcus from the white to white, or from the angle, because, the big thing, the OCTs are going to be better for ICL sizing. And it was like, well, is it? I mean, you can predict the sulcus diameter from white to white, and you'll only have 38% of the eyes that have an error of more than 0.5 millimeter. Well, that's a whole lens size different for the ICL. If you use the angle diameter, yeah, it is better, but you still have 32% of eyes with more than 0.5 millimeter diameter in error of predicting the sulcus, which is a lens size. We tried a multivariate regression analysis model using all of the measurements that you could possibly get from the anterior segment. And if you had a multivariate and used ACD and angle, you could get it down to 26% with, only with 0.5 millimeter error, which is useless for predicting sulcus, right? That's 1/4 of the eyes with an error of more than 0.5. So if you look at the insight repeatability, which is 120 microns of lateral repeatability, the chances of having an error of more than 0.5 diopter drops to less than 1%. So this is our preliminary work, right? We were saying, well, obviously measuring the sulcus directly is going to be 25 times better than using any form of highly sophisticated multivariate regression analysis of trying to indirectly predict the sulcus diameter. Well, handheld ultrasound only gets the same results as white to white, so there's no point in using it. And you had companies that were saying, well, it is better if you're a well-trained individual, you can get good handheld scans, but there was a lot of inter-observer variability with handheld devices. Obviously, the disadvantages being that the patient, has to either have an immersion cup put in, which is rather uncomfortable, or a condom put over, but then, that kind of squashes the eye a little bit, might distort the anatomy. And, not to mention this, but the resolution is lower, okay? Because we are raising the standard with this high resolution robotic scanner. And that is quite easily seen.
You're going to lean forward, turn your head slightly towards me.
This is a video demonstrating that
So you're just looking at the line, raising the eyebrow.
the whole scan sequence is done in 2 minutes. It's a lot less inconvenient than a handheld device where you have to lie the patient down and put a cup in and put some coupling medium in. The whole scan in our clinic now takes 2 minutes, 2 minutes per eye, and it's really, really very, very, very easy to do. I have all of my technicians, I have 8 technicians for all our scanning, and they're all trained and they can all do insight scans themselves. Carlo very laboriously went through all of the handheld devices and demonstrated the repeatability of the sulcus. His preferred device was the Sonomed at the time, but then he was able to get an Artemis 2 actually in Milan and was working with that. And with the Insight, of course, we managed to get far higher repeatability because of the robotic scanning being much more accurate. So comparing the resolution of what's called high frequency ultrasound with what I will call very high frequency ultrasound, they're not comparable. You cannot see the same level of detail within the posterior chamber, which is where you want the detail to be able to see where foot plates are lying and to be able to measure ciliary body sulcus to sulcus distances. It just isn't easy to find those fiducial points with lower resolution. And as I mentioned, our analysis of where these foot plates go taught us a lot about how to do this surgery better. In fact, my variability in foot plate position now is much, much lower than it was before we started studying where all of these things go. So understanding these tilted outliers that we think might need exchanging because the angle's lower, well, I actually can do this scan and know that I only have to do is go into surgery and just push that old foot plate down onto the zonular plane, and then I don't have to do an exchange and I don't have to sacrifice endothelium. And it's a much quicker operation and it's much easier. So let's finish off here by talking about our new sizing model. In our studies, we then went and did a retrospective analysis of our sizing and found after a few, we had about, I think we had 42 eyes in the first analysis, and we found something shocking. We found that a measurement which I had randomly just thrown into the multivariate analysis ended up being the most powerful predictor of ICL sizing. And that is something which I randomly called the ciliary body inner diameter. And I thought it was going to be pointless. I'll tell you why, because ciliary processes are floating around sometimes, and you can catch them on a scan and then not if you're in a crypt. So I was like, well, that's going to be useless, but let's throw it in anyway. And anyway, ciliary body inner diameter with the scotopic pupil pre-op and the sulcus to sulcus lens rise turns out to be the golden triangle for ICL power. And it turns out that sulcus to sulcus, out the window, doesn't work anymore. In fact, we couldn't even jam it into an equation because once the ciliary body inner diameter was in there, it was so much more predictive of sulcus of the ICL volt height that you couldn't get the sulcus to sulcus in as well. So our training set, like I said, was in 42 eyes. We then used that formula to do another 36 eyes. And then we used all of the eyes to do another version. And then we did another 69 eyes with that version 2 formula. So here's very high frequency ultrasound with an Insight 100 using the Kojima. And you can see that we got a mean volt of about 500. And our interquartile range was 390 microns, but our top to bottom was 800 microns. That was using Kojima. When we analyzed those eyes and formulated Formula 1 and then did the next set of eyes, our interquartile range went down to 169 microns. And when we reanalyzed and did our Formula 2, it went down to 131 microns. Our top to bottom, our highest to lowest ICL, they were only separated by 573 microns, the top and the bottom. So our original formula, not quite linearly calibrated, but now the Formula 2 is very, very nicely calibrated between the target and the achieved volt. So we put our formula into this website, iclsizing.com. We based it on the ASCRS calculator concept for the IOLs, where based on how much data you put in, so you will get all of the or some of the formulas being calculated for you. For our formula, as I showed you, you just need the sulcus to sulcus lens rise, the ciliary body inner diameter, and the scotopic pupil size, and obviously the power of the lens, and it will give you the 4 sizes and what the volt is expected. So that's free to use for anybody. And, I want to just finish by just, iterating the fact that this highly engineered device is now able to measure and image the entire capsule and zonules and measure volume. And so operating behind the dark side of the moon now gets and becomes a reality. It's actually a reality. Volume of lens, diameter of capsule, these are elements that have hampered accommodative IOL science because, the haptic length is relevant if you've got a mechanically driven accommodative lens. So possibly this technology will enable accommodative lenses to become more effective and more predictable, particularly as this equatorial diameter is so precisely determined by this robotic scanning system. And as I mentioned earlier, we're in the throes of beginning a prospective study, where we're looking at zonular anatomy, and we're trying to see if we can actually get into this ELP problem in a way that has never been achieved before. And everyone, you read all of the best people who know everything about IOL, Norby, the Norby review paper, you read all of these papers and they all admit it. The biggest problem with IOL power calculation is not knowing where the effective lens possession is going to go. And it's about 25% of the accuracy problem. So it doesn't matter whether you use ray tracing or AI or whatever you think you're going to use to get it better. Measuring directly where things are going to go obviously is going to give us better results than predicting it from other parameters. So, in summary, yes, we have lots of OCT applications that overlap with ultrasound, but actually ultrasound has its unique uses, particularly in the posterior chamber, but as a better way of getting definitive diagnoses in the cornea, in the epithelium, intrastromally, when our OCTs don't quite make it for us, even though they're very convenient and wonderful devices to use. So the highest standard of care is to be using both technologies, not just one of them. And the advantage is that the ultrasound one is actually a lot less expensive than the OCT one. So it turns out that it's not that bad a deal. So thank you very much for your attention. I hope that was of particular interest. And I suppose I will take questions if anybody is there. Otherwise, thank you very much. And I'd be very happy to answer any questions that anyone wants to email me. My email's in the bottom right-hand corner of the screen.